Good afternoon. Hello, shall we start? Dear students from the back side of this hall, I would like you to sit over there in front places, because we still have available chairs in here. Dear rectors, deans, dear professors, dear students, today I have a pleasure to introduce you the great person, yes, the great professor. Those who had this opportunity to be there 1 month ago, so you know her very well, and you had this lucky to listen to her lecture. Today, Professor Christiane Richter-Ehrenstein from Frankfurt, she's going to tell us about cancer risk in gynecology, plus how should we advise our patients to reduce their risk. I don't think so that I need to add any words for this lecture, because I'm sure it's going to be, as the previous one, excellent. I would like to add maybe one more sentence, that this is our 5th meeting with science. And as far as I'm concerned, it is a very, I'm very proud of this event, that you come here. I don't want to mention about the pluses that you got from the different subjects or points, additional points. I don't want to think about that. But thank you, all of you. Thank you that you come here, and I think it's really worthy to hear about the different subjects in the different areas of the medicine, because remember that you're going to be doctors, some of you very soon. So I think that it is important for you to expand your knowledge all the time. So thank you, and I would like to invite Professor Christiane here and tell us about your subject.
Thank you very much. Dear students, I'm always astonished to be on Tuesday afternoon and see you all. And so, thank you very much for the invitation. It's a real, I feel so honored to be with you. In this, I think you, as mentioned the last time, this is university. And keep it in your mind, if you're going to a small hospital, to a private practice, remember as it was, sitting here with 200 other guys, and listen to a talk and thinking a little bit more about what you thought before. So I think this is the opportunity, take it. Today I make more from bench to bedside. So it's a practical talk about gynecologic and gynecological risks. I think the half of you are female, so perhaps it's more personal. But for the male side here, it's for being on the side of your patients. And so I will start now to everybody, dear colleagues, dear honorable faculty, and all the students. I'm very glad to be with you today. So, in the overview, the incidence of cancer in Europe, some slides I would go to you with what do we know about cancer, general risks. Then I would talk about the specific risks for gynecological cancers, and then there are some prevention strategies I would mention. So these are data from the European Commission, and these are data from 2020. And you see, these are the cases most commonly diagnosed cancer in 2022. And we see in Europe 1,300,000 new cases for women and 1,500,000 cases for male. And you see on the left side, for the women's side, you see the most of them is more than 29% is breast cancer, then colorectal, trachea, bronchus, and lung. The corpus uteri is the 4th, and the melanoma is the 5th on the female side. On the male side, you see prostate cancer with 22.7%, then lung, then colorectal, bladder, and kidney. These are really valuable data. It becomes uncontrolled, a malignant transformation then initiates. The transformed cells gradually accumulate additional genetic mutations, and simultaneously, the microenvironment evolves from being tumor suppressive to supportive to malignancy. I think this is a very clear graphic. I think you can use it for later on for your work, but I think you will. This is from Nature from 2024. So if you are going to have the detailed, it's on the bottom. So the general risks we know about cancer. This is a very busy slide, but you see on one slide everything which we know about tumorigenesis. If you go with me to the upper left side, you find A, and these are the factors which rise the chance or the risk of getting cancer. So on the first side, these are chemical insults and radiation. Radiation can cause cancer, but sunlight can cause cancer as well. And these are, don't be afraid, we are not going to the details in the molecular way, because otherwise we are sitting here together tomorrow morning. So only to have an overview, chemical insults and radiation can cause cancer. On the other side, to go to the opposite upper side is B, it's the diet. The diet can cause, by hyperglycemia and different stages, the proliferation and the induction of cancer. Then we go one step down to the microbiome. So our gut seems to be involved in the process and malignant transformation to our body in the whole. So our food and our body and our gut seems to be a very important position, has a very important position for our cancer risk. Going to the left side, you see D, it's aging. You see this old man. So aging per se is a risk of developing cancer. And in the middle, you see E, it's inflammation. Inflammation is a process which is caused by different factors, different mechanisms, like hyperglycemia, like other things. Inflammation is the main cause of cell transformation going from a normal somatic cell to a cancer cell. I think this is as well from this Nature Aspect article I see on the right side by Mrs. Wang, and so I think if you want to go into it, it's a very nice paper. If we look, this was from the broader point. These three things I put on the headline: smoking, alcohol consumption, and obesity are the main general risk factors. And as you see below, these are standardized rates for 100,000 inhabitants in Europe and in Germany. And as you see, for smoking, I didn't translate it, for smoking, around 20% of the inhabitants smoke. As you see, for the alcohol consumption, around 10 liters per person are used or are drinks as a complete alcohol in Europe, and for Germany a little bit more. I think perhaps here in Szczecin we are on the same way of drinking too much alcohol, perhaps. On the bottom line, you see adipositas or obesity. So this means around 50% of the normal population in Europe and in Germany as well has gained too much weight. So these are the main risk factors. For breast cancer, we have very good data for breast cancer. I don't want to mention today breast cancer. I'm concentrating on gynecology cancer. But breast cancer, we know very into the depth that alcohol consumption is a very high risk factor. And as you see, in comparison to non-drinkers, if you drink as a normal adult woman, as we and you, around 40 grams per day. 40 grams means you have 1 glass of wine every evening. That makes a risk, more risk of 30% than not drinking. And this is quite a lot. If you're thinking, just be honest with yourself. How many of you drink 1 glass of wine per day or drink 1 large bottle of beer? For male, it's a little bit different. Male around need 10 grams more. So for them, 1.5 glass of wine or 2 glass of wine and 1 or 1.5 bottle of beer is just, it's a biological continuum. So you can't say, okay, 1 glass is okay and 2 glass is not okay. But you have to be always remembering that alcohol is one of the highest risk factor we in Europe putting ourselves into risk for drinking. And 1.5, and it's 150 milliliters. This is a small glass of wine. So think about your personal attitudes. Now I will come to specific risks for gynecological cancers. Ovarian cancer. Ovarian cancer, these are data from Germany because I have not the data from Poland. We have newly diagnosed ovarian cancers by 7,200 per year in Germany. The mean age is 38 years, and known risk factor for ovarian cancer for the main issue is genetic predisposition. That means 1/4 of the cases are driven by a genetic alteration which you inherited by your mother or by your father. Childlessness is a risk factor. Hormone replacement therapy in the menopausal stages, and asbestos, age, and obesity. These are the main known risk factors for for ovarian cancer. With ovarian cancer, we have the problem that we don't find it early. So most of the patients we will diagnose with ovarian cancer at higher stages. So at the end, we will lose 75% of patients with ovarian cancer and they will die of the disease. Only 25% of patients with ovarian cancer will survive. So what is the main cause? And these 25% of the inherited conditions, these are mostly tumor suppression genes mutation, and you find them. This is BRCA1 and 2, this is PALP2, this is CHEK2, this is PTEN, and TP53. These suppressor genes, you will find them all over the place. For pancreas, for stomach, most of the tumors, we know which mutation in which genes can cause cancer. And for the ovarian breast cancer inheritance, BRCA1 and BRCA2, this BRCA1 and 2, are the most important ones. So just a short list how we manage to have somebody who has 2 sisters and 1 mother with breast cancer, ovarian cancer. And we do have, you see on the left side, how is the family history. And if you see just one example, you have 1 relative with breast cancer and 1 relative with ovarian cancer, and then you have a risk of 48% having a mutation in BRCA1 and 2. So this means you have the chance of 50% getting an ovarian or breast cancer. For this woman, we have special programs, but only to be a little bit realistic, what means familial history of cancers. The next one is endometrial cancer. It has a higher incidence, is 11,000 per year in Germany. The mean age is as well 68 years. And the main risk factors for endometrial cancer is estrogen therapy alone, it's obesity and diabetes, it's genetic disposition, and it's tamoxifen. Tamoxifen is a medication against breast cancer. So the endometrial cancer has a better result for a better prognosis. 70% of the patients will survive the endometrial cancer. Most of the time we can find it quite early because the women are bleeding after they had their postmenopausal phase, and we can therefore discover them. The cervical cancer is a very astonishing cancer because this is the one we have really a known risk factor with us, which is so important that I will go more into details. We have around 6,000 cases per year in Germany. The mean age is much younger, 52, and the main risk factors are HPV infection, smoking, immunosuppression. HIV-positive patients has a higher rate of cervical cancer disease, and multiple sexual partners. This is because of the HPV infection. This is the picture of a virus. These papillomaviruses, we know more than 150 types, subtypes, and we know around 20% of these subtypes of HPV has a high risk for developing cancer, and there are around 18% which have a low risk. It's a very small virus, and the virus is, the most important virus you perhaps should remember is number 16. 16 is the most potent type known to cause cancer at several sites. And this is not only for female, it's also for male, and this is the main dominant for homosexual male, that they have a quite high rise of anal and throat cancers driven by HPV subtype infection. This, I think, is a very nice summary of the development of cancer for the cervical cancer. So the virus accessing the basal membrane, you see on the left side, through microalteration. There must be some kind of wound on the portio-uteri where the virus can go into. Then there are several genes by the virus is expressed, and then it replicates inside the cell. The virus is going inside the chromosome, it's DNA. Afterward, it goes firstly episomal, and later it has the potential to integrate into the DNA from the cell itself. And you see on the upper side, you see from the normal surface to a low-grade and high-grade lesion, and then to go to invasive cancer. This is a long story. It is not by 2 weeks or 3 weeks' time. It's a long cascade of different aspects of the evolution. And this is only a short picture how we see what we know about this HPV infection. Just to remind, perhaps somebody is not familiar with gynecology, perhaps most of you, you see on this slide the uterus, and there is this squamous cell columnar junction, which is the tissue where two types of tissue just nearby each other. And on this side, we have the main point of infection. You see on the left side, this is a normal portio-uteri, which we see by colposcopy. This is a magnification which the gynecologist can do by treating the patient. And you see this where the arrow is. This is the transformation zone, or this squamous columnar junction where the HPV infection is going to. You see on the left side, because we are not only bench, we're doing bedside, you see the macroscopic changes in a portio-uteri from being normal on the upper side, then having a dysplasia, which is these leukoplakic sides on the portio, and then on the left, on the lower picture, you see this is a cervix, this is a cancer picture. You can see with your own eyes. You don't have to have different tests. We do this test, but this is just by looking on it, you know this woman has a cervical cancer. On the right side, just by a short brief going to the gynecology clinic, you can treat this woman. First of all, you took some biopsy. Later on, if this is going to progress, you can do a leap conization. You take the cervix out. You see it on the slide. And if there is no way of if you have to diagnose a cervical cancer at the end, you have to do the operation of a total hysterectomy. And you see on the right side, this is a very heavy operation you have to perform on your patient, and the very painful, and this causes a mutation of the woman in it all. If you see the process of the HPV infection and the immunity, 80% of you in this hall will have perhaps an HPV infection if you have no vaccination. In my time before vaccination, as I was 18, probably I was HPV positive. But 80% of women have the chance of a regression and by the immune system to get rid of the infection. But by 20% of the patient, the immune system can't get rid of the HPV virus, so it maintains. And over the years, you see on the bottom, you see it took probably 15 to 25 years from the first infection to develop cancer at the end. So we have different ways to treat this. First of all, we can have HPV prophylaxis. This means vaccination. We can do screening programs. We can later on to the prevention, and at the end we can operate on these patients. So what do we have for prevention? It's only for your knowledge at a whole, there are 3 different preventions. First of all, primary prevention is the prevention that a cancer is occurring. The secondary prevention is early detection, and the tertiary prevention is preventing the spread of a cancer. So we go to primary prevention. For gynecological cancers, the important primary prevention is vaccination against HPV, and I hope the most of the female students in this room are vaccinated. The second point, lifestyle. Food, body weight, smoking, alcohol, and physical exercise on the pro side are very important primary prevention methods. As you see on this slide, women who train regularly 1 to 1.5 to 2.5 hours per week. This is not very much. This is at least 2 evenings, 45 minutes walking, fast walking, reduces, for example, here for breast cancer, the risk by nearly 20%. There is no other intervention which is so strong than physical activity to reducing cancer risk for women. There are some hormonal intervention, I would call it hormonal intervention. Multipurity and breastfeeding have a very strong reducing effect for breast and ovarian cancer. The use of hormonal contraceptive, and I think this is very important that you realize, having in mind what is on internet and what is on FaceTime, contraceptive reduces the risk of endometrial ovarian cancer by 30%. You have no more chance to reduce your risk for ovarian cancer than taking a pill, not getting pregnant. Hormone replacement therapy increases, on the other side, the risk for breast cancer from 10 to 14% lifetime risk. So taking hormones after your regular time for being fertile increases the risk of having breast cancer. So now, secondary prevention is the early detection for cervical cancer by PAP and HPV tests, and early detection for breast cancer, you know, mammography screening is on every newspaper. So only to remind you what is cervical screening for cervical cancer, it means this pap smear. Most of you, of the ladies who are in this room have had a pap smear with their gynecologist. It's taking some superficial cells, and then you see these abnormal cells under the microscope. What do we know about the adherence and the utilization of women in Europe, whether they take these opportunities of prevention for cancer? is used in the middle breast cancer. Around 66% of women in Germany and all over Europe go to mammography screening and take this chance of having an early detection of breast cancer. Around 60%, 66% going to cervical screening to prevent or to detect a very early lesion for cervical cancers. And you see for the screening from gut or for abdominal is lower because it's, I think, more aggressive and has more notification, which is negative. So we have there around 40% are going to the screening for abdominal, for the pancreas, not for pancreas, for gut and abdominal cancer. So my second last slide, take-home message. Preventing cancer, it's not easy, but I think we have all the opportunity to do it for ourselves and to teach our patients what they can do for themselves. Don't smoke, maintain a healthy weight, exercise regularly, eat a healthy diet, drink alcohol in moderation if at all, protect yourself from the sun, protect yourself from infection, and get screening tests regularly. This looks a little bit hard, but it's not too hard, so I can only emphasize that we can have a strong impact on our risk and on the risk of patients to get cancer. So thank you very much.
Thank you very much for interesting and a great lecture. I think to myself that it is very good. It was crucial for all of you, students, plus, first of all, you're going to be a doctors, and second point is that you're going to be a future, you're going to be a parents. So how important information we got as a parents, yes? How to take care of our children and how important, for example, vaccination of the HPV. So thank you very much. Any questions? Any questions from the public? What would you like to ask? Okay, so here we've got some questions. Professor Sebastian.
Yeah, that's that faculty is a little bit higher age as the rest of the audience, so we are really interested about the risk and alcohol drinking. So, if we stop the smoking, we need the sum of time to reduce risk, although we stop today. Mm-hmm. Do you know maybe how to change and how we decrease the risk for example, breast cancer if we stop drinking today?
Okay.
And we are over 50. That's compared to people who are in majority here, it's more or less 25. To the first. Yeah. And the comment, very important for the young ladies, HPV prevention. We talk only about the generally cancers, not only the cervix, but also the throat, the anus, and so on. Yeah. But you should also know the high-risk HPV vaccination allow to decrease and improve perinatal outcome. Mm-hmm. They decrease risk of preterm birth. If you start to be pregnant and you are HPV negative, you have lower risk preterm labor. This is also new knowledge and you should know about it.
I didn't know. Thank you very much for the question. For the second information, I didn't know. Thank you.
2 weeks ago, the lecture, so I wanted present.
Thank you. So with this problem of reducing or stopping with some risk factors, and then what would you get out of it at the end? Because it's a biological, a marker. We know by smoking it's 10 years. 10 years stopping, then you know you're at the risk where we before. So I have no idea. So I think, to be honest, I have no idea. I will go into the papers. If we have any kind of studying women quitting off having their wine glass in the evening and then in the 10-year time. So I don't know. I think it's always a question in the middle. So relaxing and having a nice time with somebody friendly is always a good idea. So me, myself, I'm drinking wine, whatever, so but not on a regular basis every night. So I think we have to think about regularity. And so I think this is, you have your parties on Saturday. I don't want to make any problem with saying, okay, you have to be anti-alcoholic, but I think we have to be aware of this risk. But I have no idea. Perhaps 10 years? I don't know. Well, we discuss it later. Thank you.
Remind for my wife, we should also vaccinate not only women, but also the boys. Yeah, that's
Absolutely.
The cancer, the boys, and to avoid the transmission, which unfortunately the reason of the infection. Yeah. I always get the support.
That's very important. May I ask the audience, do you have an idea, I see you, do you have an idea how many young girls in Germany, I know it only for Germany, who are 18, what is the percentage of being vaccinated? Just give me an answer, or just a limb. What do you think? 20%, 50%, 80% of young German women are vaccinated against HPV? 40, 45, something else? 47, you are very good. So 47% of 18-year-old girls in Germany are vaccinated. This is not enough. And for boys, it is 5%. And as you know, we have our rules to vaccinate children between the age of 9 to 14 for girls and from 15 to 17 for boys. So think about who is vaccinated. You can vaccinate yourself or are getting some vaccination if you are 25. This is not a problem. And in Germany, you have the chance to ask your insurance to pay at least the half of the price of the vaccination. Vaccination costs €400 for a full cycle. So you have to have 3 cycles. And if you are a child with 9, you have to have 2 cycles of vaccination. So think about yourself and getting some information for your friends and whatever for the family.
We have a question.
Yes.
Here.
Thank you for this lecture. I have one question. You just mentioned hormone replacement therapy as a risk factor during menopause for ovarian cancer. What about hormone replacement therapy in a girl who's 20 years old and suffers from hypothyroidism, for example, and is taking hormone replacement therapy for more than 20 years now?
I didn't get. Could you remember what was the hypothyroidism? I didn't get this.
Yeah, because of the hormone replacement therapy during menopause. Just wanted to know if hormone replacement therapy in a younger age, for example, 20-year-old patient with hypothyroidism, is also a risk factor, same as the hormone replacement therapy in the menopause.
Okay, so if I get it right, you want to ask me if you are just there are a lot of women who are 38 and 40 years and they get a pre-menopausal stages. So they get from pre-menopausal to post-menopausal. I had a colleague of mine, she was 38, and she wants to have a baby. And they start to try, and then she realized that it was not working. So, and then she made the test, and she was post-menopausal. So we have quite a lot of patients who are postmenopausal without knowing that they are menopausal. If you are 38 and have no regular menstruation, or you have any kind of disease where you need some extra hormonal therapy, there is no risk increasing. It's only we know that after the normal natural menopause, which is around 52, 54, then you have the problem of rising of your breast and ovarian cancer risk. But not for a woman who needs it because she is 30. You're welcome.
Any other questions?
Professor, thank you for a very long lecture. I'm wondering to know your opinion about vaccination at older women, even the small ladies.
Yeah.
The women which start the sexual activity at 25, 30 years old. What is your opinion
Yes.
on that?
There are women who have no sexual intercourse until the age of 25, and then it's absolutely fair to say this is important then to get a vaccination if they are not vaccinated against HPV. If a woman has a regular or several partners until the age of 25, 30, you can test what kind of HPV virus she has seen in her life with the males she had as partners. And then you can, the moment the vaccination has a nonavalent virus types and a cross-reaction. So I would say at least 50% chance to be in favor of vaccination. So the only thing she has to pay for it herself. But I think I would advise to go to vaccination. And with 25 as well, yes. Perhaps she has 6 and 11, and then you make a vaccination against 16, and this is the important one, and then she is safe. Yeah. Vaccination is not a treatment. Vaccination is a prevention. So if you are having a dysplasia, it makes no sense, or we don't know at least, that you are vaccinated against the HPV infection. If you have the dysplasia or the neoplasia, you can't use the vaccination as a treatment. Then we have to use other methods.
I have one more question.
Yeah.
It's not a treatment, but if somebody is infected by human papillomavirus by some oncogenic type, the cervix is in normal condition, vaccination decrease the possibility of transmission to the cancer or no?
In the moment, I think the books are not closed. So on this point, the books are not closed, whether it decreases the chance from changes of a normal tissue to a pre-malignant stage. So I think there are two schools. The one thing is you always do something good for it. So go to vaccination. This is one hand of the research, and the other hand is, okay, we don't know. So I think I'm between it. So it's not a mistake, but it's from the scientific point of view, we don't know. Yeah, right, yeah.
Vaccinated for the other kind.
Right.
Especially that we induce our immunology.
Yeah. I think because of these cross-reactions, we do probably make an immune system more resistant to the virus types we see in the next years. So I think I would go for it. Yes. Yeah.
Very quick, the two schools. The vaccination has off-label using to have the infection. Yeah, that's the prevention only. But in our country, there are many societies who concentrate on this, maybe not recommend, but suggest additional vaccination in infection. That's this approach allows or decrease the speed of the development.
I think in Germany it's not recommended in the moment. Yeah. There are two schools. Yeah,
and
right.
Definitely is off-label.
Yeah, right.
Okay. We'll have another question.
And thank you for the lecture. I wanted to ask more about the HPV vaccination program in Germany. So you said that it would be higher, the rate of vaccinations. So I was wondering, is it in the general vaccination program, the HPV vaccinations, or is it voluntary? And then also I wanted to ask, how is it organized in Germany? Is it like, for example, through a gynecologist or through school like a school nurse and a school doctor?
Thank you very much for this is a very important question. We see that if it's in the routine vaccination program of a child, so it belongs to a normal vaccination, but it's not mandatory. You are free. You can choose whether you go to vaccination or not. It's never, you don't have to do it. There's only a free choice. But we see in the countries like in England or Great Britain or in Australia, they have a very high vaccination rate. Australia has 90% of girls are vaccinated against HPV. Why is this? Because the school is doing it, and the parents have to resist that the girls are vaccinated from the group of the school. If the pressure is quite high, if the pressure is quite high by the group, and everybody goes to the school nurse and gets vaccinated, most of the girls will go. In Germany, the girls were vaccinated by their pediatricians. And pediatricians are not so keen on vaccinating children or oldest children or adults instead of their normal vaccination when they are having their in small age. So I think because pediatricians don't know what really cervical cancer means, they are not so keen on promoting these HPV virus vaccination as they are keen on influenza or whatever. So I think it's a political thing. And most of the girls, when they're 13 or 12, they don't have a gynecologist because they have no sexual partner when they're 12 or 11. So I think we have a gap there. And the school is a good maintenance of these, being informed and being a little bit pushed, I think. I think the Australian girls are pushed because everybody is going to vaccination by the school nurse. And this is not the way in Germany it's working. So, but I think and as one factor, mothers being informed that they have to go to the pediatrician with a 10-year-old girl to tell her about what is HPV, they have to discuss that their little girl is having to have a sexual partner. This is for most of the mothers not a nice idea, but it's the way it is. And so they are not keen, or they are not promoting it so much as a normal vaccination. I think there are different emotional aspects where we have these only 47% of vaccinated girls. Yeah, I think we can, like in Australia, they are going down and down and down by the cervical cancer. Cervical cancer is in 99% driven by HPV. So we could get rid of cervical cancer if we would have a vaccination rate of 95%.
Okay, we have a boy from here, right? You want to?
We would like to thank you for the interesting and accessible lecture. Basically, we would like to ask a question about the hormone replacement therapy and the hormone anti-conception. So why is one of the hormone replacement therapy protective?
Not protective, yeah.
And how long does the effect persist after stopping the technique?
Okay. So you mean why is the pill, the contraceptive we take when we are 20, why is it protective and why is the other not protective? This is a very interesting question. Thank you very much. I think it's because when you're taking hormones as a contraceptive, in a contraceptive way, it tells your body that there is no normal cycle. And the normal cycle is the problem for the tissue to have these rising estrogens and decreasing, and rising and decreasing. This is not the absolute estrogen level, it's the problem of rising and falling and rising again. So the contraceptive pill is having, the hormones are on a regular base, and the tissue seems to be very happy with this, to have an estrogen which is on one level. So it is therefore decreasing the risk, the pill is decreasing the risk of ovarian cancer and endometrial cancer, and for breast cancer is 0. So it makes no it's no increase in breast cancer if you're taking the contraceptive pill. But it's very clear evidence that afterwards it seems to be a different aspect, that you are promoting the estrogen, the tissue which is normally not prone to different estrogen levels. So I think it's because of the cycle. The cell cycle is the most prominent thing. It's the same estrogen, but it's not the same mechanism on the tissue. But no, because I mention it, because if you're going, in the last 20 years, we loses 25% of girls taking the pill. I mean, really loses. Because I think it's really worth thinking about taking as a contraceptive the pill. Because you have safe contraceptive, you are not, don't have to rely on your boyfriend, which he can use the condom properly. This is always a point for the girls, that this can be a problem. So I think a very safe contraceptive is a very good point for young women. On the other side, it really reduces your risk of ovarian cancer and breast cancer and endometrial cancer. So in the internet, the contraceptive use of the pill is very badly noticed. So if you're going on the internet, you see so many notices on Facebook or whatever that the pill is dangerous or whatever. So I'm really trying to inform young women that this is not the case, and it's worth thinking about taking the pill if you need it. Yeah.
Only inform the audience about the reality in Poland. You asked about the German situation. I would like to use this lecture to show the reality in our country. We start the general program vaccination of young women a couple of years ago. Australia has over the 30 years of experience. And it's not obligatory.
Okay.
It's range without any fees. It's between 9 and 13 years old, both the girls and the boys.
Okay.
But you should know the access is full. Only less than 10% young people take the vaccination. And I would like to inform you and ask about the increased awareness, how important are this very easy, very accessible vaccination, which allow to decrease so dangerous and so high complicated health situation. So please remember about that and share this knowledge in your families, in your environment, because this is in your generation. I hope so we change the reality. Thank you.
Thank you. May I have a question? Who is doing the vaccination in Poland? Are the pediatrician or the gynecologist? Or
yes, gynecologist has no access.
Oh.
Generally, the GPs.
Okay.
And there's also arranged the free action in the schools.
Okay.
But it's for reimbursement. Yeah.
Okay.
In this, the 4 years, between the 9 and 30 years old, is a for reimbursement.
Okay.
Yeah. We know that up to this year is satisfied 2 doses. Yeah?
Okay.
After 15, we need 3 doses.
Yeah.
That's
the same. Yeah.
The cost effective.
Yeah. Right. Excuse me? Yeah. Okay. Pediatrician as well. Okay. I think it's the why we are not very in Germany. We have a quite what's the word? Criticism about vaccination. So, like our children, the small ones, they have a vaccination around 85 to 90%, but not 100. And I think it's a society discussion at the moment. But I think to be only 47 or in Poland 10%, I think this is just way too, and we are not very good in it as well. So I think we have to think about this as a point of discussion in the society.
Thank you very much for this really, I think it's a very important lecture. So as Professor Krapowski said, be aware of this. Yes, you are the students of the medicine, plus share this knowledge, because this is your responsibility and the future is in your hands. So thank you.
Dear Christina, it was a great pleasure to see you once again in our university, and we would like to thank you. This is the same gift, but believe me, this is a gift from our hearts.
Thank you very much.
Yes. So thank you very much.